The next presentation will be given by Ms. Rachel Guest, and we go on with the surgery, updates on the surgical management of cholangiocarcinoma.
Thank you very much, and good afternoon, everyone. So just following on from John, really updating you on a few more things that are new in the surgical treatment of this disease, and particularly focusing a little bit more on transplantation and its role. And we heard very articulately yesterday about how difficult it can be for patients to navigate their journey to surgery and to know whether the care they're getting is the very best treatment or whether things are just not possible because of the inherent aggressive nature of the disease. So in this talk, I'd like to try and clarify a little bit about what outcomes are realistic, what can we actually expect in terms of getting to an operation and getting through that operation back to a good quality of life. And what is the role, if any, of transplant plays in that. So this is the most recent review of the data for intrahepatic. So I'll divide my talk into firstly intrahepatic and then peri-Hilar disease. So published in Journal of Hepatology a couple of years ago, and this table lists all the studies that have looked specifically at intrahepatic cholangiocarcinoma patient outcomes following surgery. So the first thing to notice is really the small numbers in some of these studies, some of them really only case series. There are big studies included, but we've heard from Stacey and other people about how many patients are really coming through. And I think these types of reviews really highlight the need for more of us to be publishing our outcomes and getting a better picture of survival after surgery. So if you look at the first column highlighted, looking at perioperative mortality, which is defined by this review as 90-day mortality, you can see the huge variance in the case series from a very, very respectable 1% through to 9%, which is, super high risk surgery. So this becomes really difficult for clinicians as well as patients to think, what are the actual risks of the operation that I'm facing? When we look at the 5-year survival, similarly, after all these studies, there is, again, quite a wide distribution in the variance of the data. But these data do compare similarly to other hepatopancreaticobiliary cancers, so like pancreas cancer of the order of 20 to 40%. So the best studies, 40% 5-year survival. And that's the conversation that we have to have in the clinic with our patients. What is the chance of me going through this life-changing operation and still being here 5 years after that huge surgery? Disease-free survival, so a marker of recurrence of the cancer after your operation, is often not reported in these studies, but is generally high. So this was a study, quite a large study of about 500 patients, published firstly in Annals of Surgical Oncology and then in JAMA Surgery, that looked at patients who got through the operation. So not those patients who'd succumbed within 30 or 90 days after surgery, but those who'd gone on to have some degree of survival. So what is the realistic chance of me having a long-term cure after surgery? So similar to other cohorts, they found that, sadly, the majority of people are not suitable for surgery, either due to the tumor size, the presence of liver disease, such as cirrhosis or portal hypertension, or metastatic disease. They showed a similar 5-year survival after resection, and they showed that if you exclude people who succumb to complications, they cite this rate of 9.7% of people having long-term cure. So when we're faced with people in the clinic, having that conversation of what is the chance of you being alive in a good period of time, it's realistically going to be sadly less than that because this has excluded a good proportion of the people. And the majority of people, it is due to recurrence. So there's new guidelines in addition to the ESMO guidelines published this year by the EASL-ILCA consensus group, international representation of that group, just updating recommendations of what our pathways should be during surgery and what are the new evidences that we should be looking at. There is some evidence, although this is very early days, looking at what we call anatomical resections versus non-anatomical resections. So these are operations where we take away either the left or the right liver or an anatomical chunk of liver, as opposed to carving out the liver. That is a more common procedure, for example, with colorectal liver metastasis. And there is some data that having an anatomical resection, a much larger operation, gives you some survival benefit. This is similar to data that's been seen in HCC, but this is really early days and really low numbers. So this is very much a work in progress. Other recommendations include that minimally invasive access surgery should be considered, so robotic or laparoscopic surgery. I think, sadly, for the majority of patients, especially with the large tumours or the higher tumours, that's not possible. But for people who are caught early, that should be considered. And as John has already said, routine lymphadenectomy should be undertaken now for everyone, if only to stage their disease more accurately. So more controversially, in the UK, there are a couple of recommendations in these guidelines that include consideration of vascular resection and also repeat resection for people with recurrence. And I think that would not be, at the moment, considered standard practice in this country, certainly. So where does transplant come into these things? So there will be patients who present with disease that is just not suitable for resectional surgery, either because of, as John has described, the future liver remnant is just not sufficient to sustain life after the operation, either because of its size or its quality. And so these guidelines have set out contraindications to resection and giving us a guide of less than 40% in the presence of chronic liver disease. So there will be situations in which they can suggest that transplantation should be considered, and we'll look now at the evidence presented for that. I think we're not moving on. Okay. So principally the evidence has come in what we call very early intrahepatic cholangiocarcinoma. And this has really come about from patients who've undergone transplantation for other reasons, principally a preoperative diagnosis of presumed HCC. And it's been found to actually in the explanted liver following transplant, been found to be a biliary cancer. And then people, particularly the Toronto group, have looked back and looked at the outcomes from these patients. Again, the data are very immature, quite small numbers here, but they have shown good 5-year survival in people who've got very small tumour, so 2 centimetres or less. And they've compared survival in people who've got what is termed advanced and early disease and have shown good outcomes in this context. So this combines data both from the Spanish multi-center studies, but also from the Canadian groups. And this has led to people proposing that transplantation could be considered for these sort of quite niche situation where people have got a very small tumor, but not considered to be resectable by general surgical means. So, obviously this is good news for these patients, but I do want to stress this is quite an unusual situation, one we don't see all that often. There have been a couple of comparative studies where people have tried to compare outcomes in these patients with resection in patients who've got a similar size and stage of tumours, but as the old surgical adage goes, this is a little bit like comparing apples and oranges. It's very difficult to compare survival curves here. And then lastly, before we move on to the Hilar tumours, there has been a number of publications looking at case series of patients with locally advanced intrahepatic disease showing really exceptionally good outcomes after transplantation following neoadjuvant therapy. So this study was just 6 patients, and then a larger study of 53 patients showing very good outcomes. So when you're going through the literature and reading the literature, you will read about these trials, but this is very, very early days, and at the moment certainly not standard of care. So moving on to the Hilars, why are these operations so challenging, and why are so many people sadly not suitable for surgery? Well, as John very nicely illustrated with his operative photographs, these are enormous operations. They usually involve excising the majority of the liver, including something called the caudate lobe, which is a very awkwardly placed small lobe posterior to the liver in front of the vena cava. You have to excise the entirety of the bile duct, including the confluence. You can imagine how adherent the tumour at this site will be to all the essential blood vessels that are supplying what we call the porta hepatis, right in the heart of the liver there, and trying to get that tumour off those vessels, leaving a completely negative margin, as John has said, can be unfortunately sometimes impossible. So a number of techniques have been developed, including the so-called no-touch technique by the Berlin group, where this whole area gets excised without going into the tumour itself, with excision of the portal vein itself, with reconstruction of the portal vein, so reconstructing the blood supply into the liver. There are groups who've done arterial resections, but this is more controversial, and as you can imagine, outcomes are poorer in those patients. And in addition to that, all that, you need an adequate volume and function of your future liver remnant. So you can see when you're starting with your initial population of patients presenting, by the time you get through all these multiple steps to who is suitable, you do end up with a small proportion of people who can survive this sort of magnitude of operation. So what would be considered good outcomes for resection of Hilar cholangiocarcinoma? So I think Hassan has already touched on the Amsterdam data, which was very nicely published over a 16-year period. So 606 patients assessed for transplantation. You can see the initial fall off in the number of people on their radiology who were considered potentially resectable. And by the time you've gone through all the diagnostic tests, including laparoscopy to look for spread, assessment of the future liver remnant, and exclusion of metastatic disease, you do end up with about a third of those patients who went for resection, some of whom had confirmed disease and some of whom had benign disease. You can see the sort of variance in the type of operation that was required, but in a good proportion of them, they do require these big extended hepatectomy procedures. And this cohort report a 5-year survival of 44%, which we would consider pretty good in the situation, really. So there's been a number of new types of studies come out in the literature in the last few years looking at what the best outcomes should be in the best centres. And you might hear the terms either benchmarking or textbook outcomes. And these represent what, in the best hands, would be the optimal outcome if we were operating on the lowest risk patients in the best academic centres with the best teams and best critical care support. So this was a big benchmarking large study, I think over 1,000 patients in this study. Similar numbers in terms of the proportions that were resectable. And again, they show about a 40% 5-year survival. But if we look at the morbidity associated with this sort of operation, 87% of people going through these procedures had some kind of complication. And the one that we all fear as surgeons, liver failure, 35%. So this is in the best hands in the best centres of the world. 35% of patients having the surgery got some kind of liver failure. So these are really high morbidity procedures. When you look at the 5-year survivals, the proportion of people who've got who are disease-free after 5 years, I think in the best hands, I thought that was quite a striking statistic in that study, 0%. So our group in Edinburgh looked at, is transplantation an alternative to resectional surgery in patients who are not suitable for surgery. So we did a meta-analysis looking at all the data, quite challenging study to run just because of the heterogeneity of the data, the missing data, the lack of reporting, what people are not telling us. We ended up with about 350 patients to look at, and we found quite a striking difference in those patients who'd undergone preoperative treatment with chemoradiation therapy compared to those who hadn't. So you essentially doubled your 5-year survival if you'd had neoadjuvant chemotherapy beforehand, and ended up with a 5-year survival of about 65%. So that is pretty striking when we've just compared our resectional data of about 40%. And then similarly with recurrence, if you undergo neoadjuvant treatment, you halve your risk of recurrence of disease. So this has led to a number of groups, particularly Pierre-Alain Clavion's group in the States, to look to see whether in the resectable population should transplantation be considered. And they've done a number of studies, again, trying to compare the two. And I think lots of us would argue that these are very difficult comparisons really to be made. And I think you could argue that they're maybe perhaps not directly comparable, but they certainly show good outcomes. And so the mortality at 5 years after transplantation would be significantly better than resection. But the elephant in the room with transplant is, of course, graft availability and patient selection. So although these are very good outcomes and will be suitable for some patients and has actually become standard of care in the US, the logistics of transplantation in the UK mean that this is being considered now just in the trial setting. Similar study looking at sort of directly comparing resection and transplantation, also published in Annals of Surgery. People undergoing transplant had fewer R1, so positive margin resections, fewer complications, lower mortality, lower rate of lymph node positivity, and a much better complete pathological response rate. But again, these are quite sort of difficult comparisons to make. So this, in summary, I would say at best, we would be looking at a 5-year survival rate of about 40% in both intra and extrahepatic perihilar cholangiocarcinoma. In the UK, we're now transplantation is now being offered for these patients with very early disease, less than 2 centimeters, and that's been approved by NHSBT, but this will only be applicable to a very small number of people. In the Hilar setting, the emphatic trial is being rolled out, hopefully in the near future. So this particularly looks at patients with PSC and requires patients to undergo chemo radiation as neoadjuvant treatment. And interestingly, and in a discussion probably for another time, a biopsy is required to proceed down the trial pathway, and that would not be the usual protocol in many of the US centers. So the key message really is that all these staging tests and hurdles before surgery goes a long way to identifying patients who've got what we known as good biology, and that ultimately the decision to proceed to these operations needs to be judicious, it needs to be done by the multidisciplinary team and the patient surgeon team indeed, to decide whether these operations are truly suitable and something that patients want to proceed with. And I'll finish there. Thank you.